Tēnā koutou katoa, Kate Mila Fáilte, bienvenue à tous. Welcome, everybody. My name is Professor Sinead Donnelly, an internal and palliative medicine physician from Ireland, joining you from Aotearoa, New Zealand today, and introducing this 10th Drs-say-no international webinar. So Drs-say-no is an international network, so far with 563 signatories from 24 countries, to an open letter advocating that euthanasia-assisted suicide is not part of medicine. We write that doctors should be left to focus on advocating for patients, to cure sometimes, to relieve often, and to comfort always. Please encourage your medical colleagues to consider signing this letter. Today, we're privileged to welcome Dr. Wes Ely, Professor of Medicine, Vanderbilt University, Tennessee, the Grant Little Chair in Medicine and co-director of the Center for Critical Illness, Brain Dysfunction and Survivorship. In conversation with Dr. Mark Komrad, psychiatrist on the faculty of Johns Hopkins, University of Maryland, Tulane and Louisiana State University, and a medical ethicist. They will be in conversation on the topic which you see here, the death by organ donation in the setting of MAID. Just a brief introduction. Dr. Ely and Komrad will have a conversation about the developing practice of allowing patients receiving medical assistance in dying to donate their organs following these procedures. They will examine these practices in the Netherlands, Belgium, Canada, and the emerging interest in this linkage in other jurisdictions that have legalized MAID. They will discuss the ethical challenges of death by donation in this context, including issues of consent and implicit forces of coercion, particularly for patients seeking MAID for psychiatric conditions. So the chat function is disabled. The conversation between Mark and Wes will be for approximately 30 to 40 minutes. You will, all participants, please put your questions in the Q&A and I will keep an eye on those and present those to the speakers at the end of their conversation. I will now hand over to Dr. Komrad to introduce our guest further and start the conversation.
Great. Thank you so much, Sinead. I appreciate it. And I'm so happy to be having an opportunity to talk about this critical topic with Wes Ely, who, as you just heard, is a professor both of critical care medicine and also has had some particular professional experience in organ donation, because today we want to examine the ethical conundrums, pitfalls, and great concerns about the emerging linkage between these procedures where physicians deliberately end patients' lives and seeing that as an opportunity for organ donation, which raises many problematic themes. So, Wes, thank you so much for joining us. And I want to just begin off, tell us a little bit about your own personal professional experience in the world of transplant medicine and the procurement of organs. What's been your background in that?
Sure, Dr. Komrad, thanks so much. And for the audience, it's a pleasure for me to be here today. My name is Dr. Wes Ely. I'm at Vanderbilt University and work at the VA as well. And I am you can see, gray-haired intensivist. I consider myself a geriatric intensivist, which means that I focus on especially vulnerabilities of the aging, the older patients in the ICU. And this has brought me face to face with lots of very challenging and societally changing, rapidly changing aspects of critical care. I'm an internist by training and then pulmonary and critical care boarded. So 3 different types of specific training, and then have been geriatricized by years and years of working in the aging sector of research. Before getting into focusing only on intensive care, though, I was trained in lung transplantation and actually became the medical director of lung transplantation here at Vanderbilt University, where I screened and enrolled patients, enlisted patients for lung transplantation, and monitored and managed their immunosuppression and opportunistic infections, and did this for years before deciding to focus all on critical care. I am a very big proponent of transplantation. I think it's a wonderful opportunity for people to receive life-saving organ transplantation, kidney, liver, lung, heart, pancreas, etc. And so by no means am I here today to dissuade people from being an organ donor. I think that we need, though, to steady ourselves about how organ donation is handled in order to be ethically appropriate on both sides of the circumstance. That is, to make sure we absolutely uphold the dignity and the beauty of life on the donor side, as well as what we hope happens on the recipient side, which is a life-saving organ transplantation. And we'll unpack this more as we go along.
Yeah, thank you. So that really gives us a very robust background for this discussion. So just focusing first just on organ donation, can you tell us a little bit about this ethical standard that has adhered in this domain for a while now called the dead donor rule? Can you explain what that is?
Sure. The dead donor rule is really the bedrock of transplant medicine. And what it basically states is that we should do nothing to a human being to create death so that you can receive organs. That's basically the dead donor rule, that you only take organs from a dead human being. And if a person is dead, that we can then receive those organs in donation.
Now, is
And
that a law or is that just a custom and ethical standard?
it's a well, it depends on where you are in the world, but in some
Yeah.
circumstances, it's a law and it's also the ethical bedrock of transplant medicine. Although in the late teens, you began to see fairly prominent bioethicists, even in the New England Journal of Medicine, suggesting maybe we should bypass this pesky dead donor rule. Maybe it's getting in our way. And you know what happens when we want organs is, and when I was a transplant physician, and I would go to organ retrievals, get on helicopters, and go into the operating room myself with the cardiothoracic and general surgeons. What you don't want is ischemic organs. You want organs as fresh as they can be, so that when you put them in the recipient, that they function well. Well, the way you could get the freshest organs would be to take them out of a human being who is still alive. And that's where this idea, this push is coming in society now, is death by donation. Why not let somebody just volunteer? And we'll get to that in a minute.
Well, of course,
But
we
I think
already
that would
have some.
violate that would violate the dead donor rule.
We have some of that. For example, people can donate a kidney while alive, right, and still have their remaining kidney. So there are some live donor scenarios.
Okay, that's a great point. There are live donor circumstances, and we have live liver donations as well. You could never do a live heart donation because obviously you're going to die if you take the heart out. And but the dead donor rule says that if you're going to take the body's organs, their vital organs, those that keep it alive, the body has to be dead first.
Yeah. Yeah. Okay.
And in by stipulation, you can't do anything to create the death, to accentuate the death. So we'll get into specifics related to DCD, donation after circulatory death or after brain death. But as an example, we shouldn't be clamping arteries or stopping blood flow to create the circumstances of vital organ donation.
Okay. Let's now proceed to bringing this into the context of, what's been called MAID, medical aid in dying in Canada, which is a combination of euthanasia and assisted suicide. And just to remind our audience the difference between those two, in assisted suicide, a clinician, typically a physician, prescribes a lethal dose of medication to a patient who has certain eligibilities. And that patient takes that oral medication home to use at the time and place of their own choosing. Sometimes never, sometimes after very long delays. Hopefully, their suicidal grandchild doesn't come across it in the closet and so forth. That's physician-assisted suicide. Euthanasia, on the other hand, refers to the active production of death by a physician or clinician by starting an intravenous and pushing a lethal injection, just as in lethal injections for criminals, but of course here with the patient's consent. And primarily, this issue of donating organs following death caused by these procedures is typically done in the context of euthanasia, where you can be right there at the bedside when the patient dies rather than they're taking their oral medications themselves at some time in the future when they're home. And that it's important to note that euthanasia is not a practice that we have here in the United States. We only have assisted suicide, and we, although there's certainly an interest in progressing to euthanasia. That's not the case, whereas that is available and the predominant method by which doctors terminate patients' lives in Canada, Netherlands, and Belgium. Now,
Yeah, let me expound on that a little bit, Mark,
yeah,
if you don't
sure.
mind, for the audience. So, in other words, to reframe what Dr. Komrad just said, I'm going to make maybe three major points. One is that if you look at a pie chart of doctor involvement in death, intentional death, that pie chart would have a tiny little slither of 1% would be physician-assisted suicide, where a doctor writes a prescription, the patient takes it at home. 99% would be different forms of euthanasia. And of that 99% of the big bulk of doctor involvement in death, of intending death, about a third of it, 27%, according to the New England Journal of Medicine, is involuntary, where doctors actually create a euthanasia circumstance to kill intentionally in the life of a patient without the patient volunteering to do it. And then 73% is a person signing up and saying, hey, can I come in on Tuesday at 10 a.m. and get you to inject me to end my life? So
in
just remember the
jurisdictions where
difference
it's
between
legal.
voluntary and involuntary euthanasia. And then the last point I'll make is this distinction between PAS and E is not really sustainable. Dan Solmacy has written beautifully about this in JAMA, and we wrote a letter to the editor of the New England Journal together saying that 5 reasons why it's not sustainable, but 2 of them are that all the arguments that you can make in favor of physician-assisted suicide will ultimately be used by the public to justify euthanasia as well. So, for example, I could say to you, if I had profound ALS, you're prejudiced against me because I can't take the pills. I can't lift up my hands and take the pills. So I need euthanasia, and you can't prejudice against me and just approve PAS. You need to approve euthanasia as well. So those are a couple of extra points about this distinction, Mark.
Right, right. Now, I just want to show sort of what the current situation is in other countries, moving to the intersection between these two concepts, the organ donation and euthanasia. These are being linked, at least in Canada, Belgium, and the Netherlands. So in Canada, as you can see here, between 2018 and 24, 7% of all transplants that were done in that country were from donors who had been euthanized, primarily euthanized voluntarily, but that has been a pipeline for about 7% of all the organ donations in that country. In 2024, there were 60 of them. There's in Canada, and there's even a foundation in Ontario called the Trillium Gift of Life Foundation that's working very hard to facilitate this. And they've developed a toolkit that they've made available to clinicians throughout the country, encouraging them and helping them to invite patients who are considering euthanasia to donate their organs. In fact, just recently, the Deputy Director of Health and Human Services, a federal organization here in America, referred to this as a strange new horror that is really shocking. In Belgium, they've had euthanasia since 2003. They've had, by 2020, they'd had about 50 cases of transplant after euthanasia, and we'll return to that in a little bit. In the Netherlands, between 2003 and 2024, there have been 166 cases of transplants following euthanasia. And interestingly and ominously, since 2018, they created a law in which consent to organ donation after euthanasia is the default condition. You do not actually have to explicitly consent if you're having euthanasia to have your organs donated, but you must opt out if you don't want it. So the default is donation. Here in the U.S., I don't think, and Dr. Ely will correct me if I'm mistaken, but I don't think we've yet had any reported cases of donation because we don't have euthanasia here in the U.S. and donating it after this at-home assisted suicide by oral medications is just not feasible. But many advocates are pushing for it. One in particular is this prominent ethicist Thaddeus Pope, who is an advisor to the largest advocacy group, Compassion and Choices, is very much pushing for it. He believes that up to 15% of everyone who dies by these methods would be eligible and should be eligible and should be encouraged to be organ donors. So although it hasn't happened yet here in the US, we are definitely at the point where many forces are trying to make that happen. So,
and Mark, you're so right to talk about the forces that are moving things to happen. Imagine the forces on the patients who are undergoing euthanasia to become an organ donor. And let's think a little bit about how it confuses the two situations when you mix these two things together. So, for example, if I wanted to end my life but didn't want to be a donor, and somebody said, "Well, gosh, you're being so selfish. Like, why don't you just, create organs for other people?" And so I consent to it, to the organ donation. Now I've consented to two things: one euthanasia, one organ donation. Now imagine the pressure that I have on me if I decide, well, after all, I don't really want euthanasia now. I've decided I want to live. I had a patient, for example, his name was Paul, in the ICU. I had permission to tell his story. And this patient had a fatal disease, and he asked me to end his life. And I've written about this. I believe it was in USA Today. I can't remember exactly where I published this story, but I had permission to publish his story. And when Paul was asking me to end his life, I started asking him instead, "Tell me about your life. Like, what do you do?" And he told me about loving Shakespeare. He recited from Portia and Merchant of Venice, "The quality of mercy is not strained." I had a nurse 2 beds down who loved Shakespeare. She came in the room and talked to him, and they got really into talking about plays, and she had been a bit depressed, and he helped her think through some things. And the next day I walked in and he said, "I don't want to be euthanized anymore. I don't want my life to be over." I was not going to do it anyway, but it was nice to see that he had found a purpose and a why to live. If he had, on the front end, also consented to donating organs, think about how there's a conflict of interest now in the situation, because he's now thinking, "Oh, I'm now going to let people down." I think it's very dangerous when these pressures put so much on them. And this area puts an amazing amount of erosion onto patient autonomy, in a sense. People who are vulnerable, who can't speak for themselves, who have end-stage diseases, neuromuscular diseases, have written about this. And if you want me to, I'll unpack some true stories about people who have written about how they felt their autonomy was eroded. And the whole thing pushing PAS&E is this unbridled patient autonomy. And what's so ironic is that there is actually becoming an erosion of patient autonomy, in a sense, because of this. And I'd love to tell you a few examples of that if you want to get into that.
well, I actually would, because I think the area where that is really most notable is what's happening in Belgium. I'm sorry, in the Netherlands, actually in Belgium as well, with regard to psychiatric patients who are now eligible in those countries for euthanasia with just sole psychiatric conditions, because I think they are particularly vulnerable to this kind of potentially coercive milieu that can be set up. So this is some data looking at organ donation and from following euthanasia in the Netherlands. So on the left, you see that with regard to all the euthanasias in that country, only 1% of patients who are euthanized in the Netherlands are people with psychiatric disorders. However, on the right, if you look at these particular study over these 10 years of 24 organs that were donated after euthanasia, of those, all the patients for all those patients, I'm sorry, on the right are all the patients who donated over those 10 years. And there, almost 1/3 of the donors after euthanasia are the people who had psychiatric disorders and were euthanized for those psychiatric disorders. There were 24 of them that constituted basically 30%.
So that's a great example. I'm glad you put some data there. Let's personalize it, shall we? I'll give you 2 examples. I know a priest who has severe depression. And the priest, and I'm going to read a direct quote of what this priest wrote to me when he's severely depressed. When I'm mentally healthy, the thought of suicide is horrifying to me. It is beyond my understanding, though, that my brain could lie so effectively to me during times of mental and physical illness. It's apparent, however, that given enough untreated pain or mental suffering during my times of depression, my brain becomes diseased and thinks that self-destruction is the only viable option.
Right. So
I
it's a
just
very
thought that was an
state.
amazing way
Yes.
that he put that,
It's a
right?
very state dependent feeling. So,
Yes. And
however, now,
another example, let me share this one other one with you before we go on, Mark. This one, everybody, all of our audience can find this. Ben Matlin, Mattlin, wrote a beautiful, though stirring and difficult to read op-ed in the New York Times. This was just over a decade ago. And he writes about how there's a he himself has a neuromuscular disease. And so you'd think, he writes, that you think if anybody wants euthanasia, it's me, because I want to be able to die without suffering. Um, but he knows the beauties of palliative care, and he wants to receive palliative care when the time is right. And he writes, though, there is a thin and porous border, direct quote, between coercion and free choice. And he is feeling coerced by society. And he goes on to write, you also can't truly conceive of the many subtle forces, invariably well meaning, kind hearted, even gentle, yet as persuasive as a tsunami, that emerge when your autonomy is hopelessly compromised. So, are we as a society telling people like Ben Matlin or those people here who have depression, autism, personality disorders, look, please just agree to get out of the way? Get out of the way. You know, you are of less value than the rest of us in society. There's a difference. Society's saying there's a difference between a person and a human being. To be a person, society is saying you have to have some qualifications. You have to have education. You have to have self-worth, worth to society. But if you lose those qualifications and you're severely diseased, disabled, etc., maybe you should, Ben Matlin, get out of the way.
yes. Now let's imagine a person with a psychiatric disorder, a chronic psychiatric disorder, who has really had uh, the consequences of that with not being able to achieve what they wanted in life, feeling like they're behind the developmental curve, feeling like a burden on their family, uh, feeling like a strain on resources, having all of this internalized stigma that comes with having a psychiatric illness. And now imagine the opportunity that presents itself to make something, a legacy of that life,
Mhm.
by donating your organs. So here is a quote, my turn to quote a patient. This is an organ donor with psychiatric illness who ended up dying by euthanasia. And she said, I thought the knowledge of having full autonomy by way of MAID was comforting. But when the possibility of organ donation was added to it, the sense of elation is the only appropriate word for me. So the point is that I think that particularly psychiatric patients, which is my particular area of interest as a psychiatrist and psychiatric ethicist, I think this is an inherently coercive situation in which there's a virtue opportunity, a tantalization of a vulnerable person who is, by virtue of their illness and the social consequences of that, already suffering from feelings of worthlessness, to be able to see the opportunity to make themselves worthwhile, so that euthanasia is an inducement and is an opportunity for them, which I think is a very precarious situation when it comes to actually being able to make an autonomous decision.
And that's a great example. Look how beautiful she is, by the way. I'm sure was an amazing person. Let's say for sure though that it's a person's right to determine uh, what they choose to do with their life in most circumstances. And I can't tell a person what to choose. They have to make this decision for themselves. What I'm talking about, though, is when we set up a circumstance like this virtue opportunity, which then is either an indirect or an inadvertent coercion of the person's autonomy. Because true autonomy should not involve such a coercion like that. Like you can now become of value to society. You didn't think you were of value. You can become of value. When in truth, the person was of inestimable value in the first place. We know, if you take Kant, Kant wrote in Metaphysics of Morals that he talks about this idea of in the realm of the ends, everything has a price or a dignity. And if you can replace one, if something has a price, you can replace it with something else. But if something has a dignity, it's above all price. And we know that woman's life was above all price. She may not have known that though, and we in society need to remind her and show her, like the nurse did with Paul in my hospital. She made him realize that he was above all price, and no amount of disease took any of his value away. What I want us to think about is, what does it do to us as a society to impoverish us, and also to the medical profession to override a 2,500-year-old Hippocratic oath when we start allowing ourselves to become involved in the deliberate process of death for a person because we think that it's our job now to usher in, euthanasia, when we don't even know that the person who we are intentionally killing has been inadvertently or indirectly coerced into that circumstance. If I was to find that out, that I had been involved in that, and afterwards realized, oh my gosh, they were coerced, what does that do to my moral circumstances in my own situation? I've had a serious moral injury now, and I am now perhaps in need of some serious help as a healer and as a human being.
Yes, not to mention the potential moral injury to the recipient of an organ donated in this way, to know that that person actually participated in a suicide that was aided and abetted by physicians in order to give them that organ as opposed to death through disease or accident. Going
Yes,
back
and you know
to
what happens here, Mark, is that the person becomes a means to an end, and
yes,
and
I
and
wanted to make that point with regard to what you said about Kant, because in this sense, it it objectifies patients, sees them as, puts them in a position of being the instruments of utility for the benefit of others, rather than merely for themselves. And in this sense, it gives society a kind of stake in a euthanasia death. Uh, because now society gets its organs, procured, which it very much detracts from the claim that euthanasia should be ethically allowed solely because it benefits the person being euthanized. Well, it's also benefiting society. It's not merely an expression of individual autonomy, and in that sense, it creates people as not ends, but as means to the ends for others.
what we have to realize is that the this idea between what's a person versus what's a human being. First of all, the dead donor rule says that the human being must be dead to take vital organs, not the person. Society is maybe saying people can judge on their own that maybe they're not important anymore for society, but they can gain self-worth by donating their organs in a death by donation circumstance instead of donation after death. What this does to me is it will create a suicide pipeline for society, that people will be signing up to have suicide occur so that they can have value. And this is a very, very, very dangerous direction that society is going, because instead of that, we need to make sure that everyone in society knows that they are of inestimable value. Um, that's my
Well,
job as a healer.
yes, in the Netherlands, Wes, they have a conference every year called a Week of Euthanasia, a week-long conference put on by the Dutch government and so forth in order to help people develop a interest in and a relationship with the whole opportunity for euthanasia. And one of the workshops there is about organ donation. And a Canadian documentarian went and interviewed people who were attending that workshop and found that the majority of people who were attending the workshop were psychiatric patients seeking euthanasia for their psychiatric condition, who were attracted to and enchanted by the idea that this could be this virtue opportunity. So I want to progress on to talking a little bit more about the emerging interest now, not in taking organs strictly from people after they've had their euthanasia, but actually to create an opportunity for live organ donation. Currently, um, the the method is first the euthanasia and then the harvesting of organs. But what has emerged is an article in the Canadian Medical Association Journal and also the New England Journal suggesting the value of live donor transplants by first anesthetizing patients at the time that they're going to get their euthanasia, then removing a living organ prior to administering the lethal coup de grace infusion of causing death. What do you understand by this idea of this what you're calling death by donation? First donate, then crank it up to produce death.
Well, let me first say that this isn't happening, to my knowledge. I don't know this has happened, but it is not a stretch at all to think that this can and will happen. And let me tell you why I think that is possible. I was at two major international meetings a couple of years ago where every time the discussion in the middle of a room of 400 or 500 doctors, the discussion was on organ donation after euthanasia. In both of these international meetings, the conversation quickly shifted to even better, how many more organs could we get if we did this? And we took people to voluntary death so they could death by donation, donate their organs in order that that's how their death would occur, so the organs would be fresher and lack of ischemia time. When I wrote about this in the journal Intensive Care Medicine, and some authors in Europe wrote back and called it fake news. I wrote back to the journal and said, and they published this, so you can find this on PubMed. I wrote back and said, I'm not saying that it's happening. What I'm saying is that doctors, very prominent academic doctors, are having this conversation. And now it's been published in the New England Journal of Medicine and the Canadian Medical Journal. So it's not a stretch at all to think that this will occur, because if we're getting more and more organs after euthanasia, and people start saying, well, gosh, I could get this value, opportunity, this golden opportunity. She said, what she call it, the word was elation. Elation. Well, that's naturally exactly where the conversation is going to go. And we're going to have to be very careful to stop that conversation from happening. If you let it go its natural way, then it will go in this direction. I had a conversation last week, for example, with a very major transplant director, and I asked him if he would be supportive of this. And the answer was basically, I'm not, it's against the law, but if society were to agree to it, then society agrees to it. And my answer to that is, what if society agrees to the gas chamber, i.e. World War II again? We go back to that. Does societal agreement equal morality? And I think not. We have numerous examples where this has not happened. Society chose to do involuntary sterilization in the United States. In fact, the World War II occurrence of sterilization in Germany was learned from the United States. And so we've made lots of errors in societal judgment over the years, and we should not think that if society chooses it, that means that it's moral and appropriate.
Yes, and the fact is that medical ethics is very vulnerable. We are citizens in our society, and we are very vulnerable to the currents of moral change in our society. So an interesting study showed that the attitude of physicians in jurisdictions from before these procedures were legalized to after it was legalized, that physicians changed their attitudes about what their moral stance was on this after they became legal. So legal N actually started to become deployed and practiced. That the more that once it's legalized and the more experience happens with it, the more physicians' moral attitudes change. All of societies, frankly, but physicians as well. So that laws, in many ways, at least pragmatically speaking, drag along the ethics after them in just the way that you've been saying.
I imagine how quickly things could shift if we, as we expand organ donation after euthanasia, how quickly things could shift if people say, well, the logical next step is why are we throwing away all these organs from people who are otherwise committing suicide? Let's just do it in a controlled setting in the OR, and they don't even have to have a disease or anything. Let's just utilize the organs. Here's a perfect utilitarian argument. Let's not let those organs go to waste. And it just therefore affirms. And as I said, I think it would create a suicide pipeline.
Well, in both the Belgium and Netherlands, there increasingly talk and even political action towards liberalizing the eligibility for euthanasia by allowing people who have declared their lives complete or are tired of living. Those are the phrases that are being used in the Benelux countries uh, to make that alone put sufficient eligibility for criteria. So imagine under those circumstances having organ donation as an option. How much more would there be a suicide pipeline, as you're calling it, if we're now not only thinking about people with potentially diseased organs and damaged organs, but people who are otherwise healthy, which of course is the case, especially with the psychiatric patients who have, frankly, among the most desirable organs for the most part as donors for transplants because they are not at the end stage of severe organ damaging somatic diseases. So all of these criteria, first allowing psychiatric patients, then maybe progressing to tired of living or completed life, are absolutely opening wider the spigot for potential organ donations and the suction that opportunity has for pulling people into that pipeline.
I know we're about out of time here because we want to go to Q&A. So for the audience, we're about to open it up for Q&A. But let me end with 3 points that I have not made yet. One is I'd like to refer the audience to a beautiful article written in the Annals of Internal Medicine just recently by senior author Lois Snyder-Stolmacy and first author Espenson entitled Ethical Issues in Organ Transplantation, a position paper from the ACP. It's a very good article about some of these controversial areas, including consenting. The second of my 3 final points would be that in 2014, just a decade ago, there was an article published um, by international authors, first author from Israel, and Charlie Sprung, Sprung, that did a large international survey and found that 8 out of 10 critical care physicians around the world thought that it was, even if permissible by law, inappropriate to actively shorten the life of a person, even if permissible by law. So here's a circumstance where doctors are saying, I don't care what law is. I, as a physician, will not intervene to actively shorten someone's life. 8 out of 10 felt that that was morally reprehensible. And the last thing I wanted to say is just something about the patient-physician relationship. And we haven't stated anything about this yet in the talk. So I want to make sure that I make this point. It's a reciprocal relationship that I have with my patient. Pellegrino wrote beautifully about this. Edmund Pellegrino, one of the greatest bioethicists of the 20th century, when he said that this reciprocal relationship is like any ethical relationship in that the justifiable concern for patient autonomy, we have to remember that the physician is also a moral agent. And so when the two are in conflict, like I think with my patient Paul, I said, I can't end your life. No, even if you want to, the value of your life is bigger than your choice for me asking me to end your life. That the patient's wish does not automatically override the physician's wish. And physicians have to have autonomy to decide not to participate in this. And so I think that that's a very important point to make here. And I'd love for us to open it up for the audience for Q&A and see where they disagree with us, Mark, and maybe tell us where to get off or ask other questions.
Okay.
Thanks very much.
And I would like to close with a quote from Margot Somerville, who also wrote about organ donation. And by the way, Lois Solmasi is on a participant here today. Maybe she'll write in something.
Oh, great.
Question.
Hey, Lois.
But I want to just quote Margot, who, first of all, noted from a colleague in Australia that a nurse told her about how she felt the treatment team were hovering like vultures over a dying man waiting for his organs. This sense of, the appetite for feeding this pipeline. But what Margot wrote was, it is only in respecting death that we ultimately respect life, and consequently how we die matters because it's central to determining whether or not we respect life. And that is central to setting the ethical tone of our society and establishing whether or not it is a civilized one. And I think that particularly hooking organ donation into these procedures is very much souring the ethical tone that Margot Somerville is referring to.
Thanks, Mark. And thanks, Wes. I'll just read out questions at the moment. This is from Pablo, who's online. You haven't mentioned the situation in Spain, which introduced euthanasia in 2021. Euthanasia has become a complementary source of organ donation in Spain, contributing a growing number of donors and transplants, with figures that continue to rise. And they give the figure of donors 226 and transplanted patients. Organ donation after euthanasia in Spain, donors 226, transplanted patients 643. Anybody, Pablo then speaks again later on, just saying in Spain, 14% of people who died by euthanasia were organ donors. So anyone, Wes or Mark, want to respond?
I think it's just an example, and thank you for putting it in there, that not only are other countries participating, we mentioned the Benelux countries in Canada, but thank you for making us realize that other European countries around the world and others around the world are absolutely participating in this area. And there's now purchasing of organs in certain countries. I won't mention any specifically, but we know for a fact that is occurring. And this is a global problem. It's a global public health and bioethical problem that we have got to address societally on a large scale.
Thanks, Wes.
Wes, can I just ask, do you think that opening this pipeline through these procedures does stand to make, is there an argument to be made that this would significantly improve the availability of organs for donation? Do you think it's even reasonable to think that this should be a public policy?
Let me state some facts. There are people on the wait list who are going to die because they don't get an organ. That's for sure. People die on the wait list. In circumstances where you have more organs for them, they might not die if they were to get the transplant. That's a theoretical. So would it be possible to have less patients die on the wait list for example, a vital organ like a heart or a lung, if you had a much larger number of donors through suicide, through this death by donation? I think that's very likely. Put it this way, it'll be a very efficient way to get organs. And that's a sad way to find efficiency, through devaluing human life. And it would impoverish us as a society to say that these people waiting are worth more than the people donating. Therefore, there is a lack of equivalency in the value of these two human beings.
Thanks, Wes. A question then from Catherine Ferrier. Could you comment on the accuracy of brain death determination, Wes? And Catherine says she's heard that this is being questioned recently. Could a person be said to be brain dead and have their organs removed who is still alive?
Okay, first off, have there been people who were claimed to be brain dead and not brain dead? Absolutely. Do doctors sometimes erroneously make a diagnosis of brain death when somebody's not brain dead? Yes, that happens. Are they taken all the way to organ donation? That's more of a questionable thing. Usually it's picked up and figured out when they start breathing on their own after you stop the ventilator. Of course, brain death means there's no respiratory drive. So you stop the ventilator, there's no breaths. Usually this is figured out when they start breathing again after you stop the ventilator. The the UDDA, the Uniform Determination of Death Act in the United States, and the dead donor rule uphold that somebody has to be dead, and brain death is a viable way of determining death, just like cardiac death, as long as you adhere to the principles of the definition of brain death. And there have been articles published in neurological journals showing that sometimes doctors don't do a good enough job adhering to that. So we need better education. We need to follow the protocols, and we need to make absolutely certain that somebody is brain dead. And if they are, I mean, if I'm brain dead, and if I'm dead by neurological criteria, I've told my wife that I want to be an organ donor. So I believe in that concept, and I also believe we need to make no errors.
Thank you. And Catherine also just asks how could you share the Pellegrino article about the doctor-patient relationship?
Oh, sure, I will. I can tell you right now. I'll just read it off. It's from the American the Annals of the Royal College of Physicians and Surgical. I'm going to put it up here. Somebody want to record that? This
Yeah,
is
that's
easier.
great.
I'll just
That's
leave that there.
perfect.
Go with the next question, and I'm going to leave it at the bottom of this slide.
That's great. Well, the next question isn't online at the moment, but just to ask, the question is, as an ICU doctor or an anaesthetist, this will be kind of your area, who doesn't want to participate and you're in a small team, how do you manage? How does that work if
And
it's legal in the country?
and I would also
Well,
add, what about the conflict of interest? I mean, who is your obligation to the recipient under those circumstances? Are you in a conflict of interest if you are a conscientious objector because you're depriving a recipient if you were to exercise your objection?
And
okay.
how does the team function with members
Yeah,
who are
let me be very clear about this. I would absolutely be a conscientious objector to participation in physician-assisted suicide and euthanasia. I've not had to have that happen. I'm at Vanderbilt, and I'm a physician in Tennessee. It's against the law here. If they change the law, I will not participate, and I would allow myself to be arrested for absence of participation if it came to that. And I don't know that it would, but if it did, I'm happy with that. I would not absolutely not participate. Now, having said that. Um, I had a patient a month ago who attempted suicide, did not die, but was in a dying process, and the parents knew that she had wanted to be an organ donor if she died, and so she became consented for via the parents DCD, which is death after donation after circulatory death. So I went down with her and the family into the operating room. I think this should be done in the PACU, frankly. There should be a separation of this process and the OR retrieval of the organs. But we stayed with her for an hour as we withdrew support, not withdrew care, but we cared for her. We lovingly cared for her during that time. And she did not die during that time. I was actually very curious to see whether or not the anesthesiologist was going to push a ton more fentanyl and morphine and other drugs to enhance the rapidity of death. But that anesthesiologist was rule follower to the bone. We did her care exactly as it would have been done under me in the ICU. And she did not die within the hour. Some people use an hour, some people use 90 minutes or 120 minutes. And she came back up to the ICU, and we cared for her as she was dying. She did not become an organ donor, so she was not a DCD organ donor. But had she died in 45 minutes, she would have become one. So that's something important for us to outline because we haven't gone over that. She wasn't brain dead. She could have been an organ donor by DCD. She did not become an organ donor at all. And are there places in the world, this is why I brought this up, are there places that would give those extra boluses of fentanyl to make the patient die more quickly so that they can get underneath that hour, 1.5 or 2 hours criteria, wherever the rule is? And I think it'd be shocking if that isn't happening. I can't tell you it is, but I think it'd be very surprising if it isn't.
But it's one thing to say that that might happen under certain circumstances. It's another thing to institutionalize an
Yeah,
entire method whereby society not only allows it to happen, but encourages it to happen.
you're right.
Well, before wrapping up, this is a final question. Is it from the participants? Is it ethical to refuse an organ from a euthanasia donor if it is necessary to save the life of a potential recipient?
I'm so glad you brought that up because that's something I was hoping we'd get to and I would have forgotten. Here's a better thing. Should we have full disclosure? And I think the answer is yes. Should we have full disclosure to the recipients if the organs come from a patient who was euthanized? I think that's absolutely important. What if you gave a heart to somebody who was opposed to euthanasia, and they've later found out that heart came from somebody who was euthanized? That person would then be carrying this vital organ and feel who knows how much moral trauma that person would go through. And right now, I don't think that that's probably happening in these countries where you said in Spain, Benelux, Canada. Are they revealing to all these people who are receiving these organs that they came from somebody who was intentionally injected with a lethal dose of a medicine by a physician?
Yeah.
I doubt it. I don't know the answer to that question, actually.
Yeah.
Yeah.
And the degree to which that was consented to in advance, which, as you point out, it's sometimes not under extreme circumstances. No, I think that the moral injury to the recipient is a very, very important and poignant point. Thinking like a psychiatrist, imagining trying to deal with somebody in that situation whose life not only has been given by this, but who literally carries around the residual of that act. I think that ethically, it is absolutely vital to disclose that to the recipient.
So thank you both very much. Extraordinary. It was such a brilliant idea of Mark's that to be in conversation with Wes as a way of presenting this webinar. So thank you so much for the depth and quality of this conversation. Just to say, we will send out notice for further webinar in the series, and you're welcome to email me with suggested speakers, and we're keen to facilitate speakers in a variety of languages. So once again, to thank Wes and Mark for this brilliant conversation.
Thank you,
Thank
Wes.
you all. Appreciate you being here.